Good evening. Thank you for joining us. This is the final public meeting in our series of public meetings to discuss your care, your views. And that is our name for our public engagement programme to discuss proposals around redesigning our sites and our services. This evening, using Zoom, we ask that your microphone remains muted and that your camera remains off. But there is going to be plenty of opportunity for you to ask questions at the end, and we'd be grateful if you could do that using the chat function. We want to tell you tonight a little bit about our engagement. There's not a lot of time left for our engagement programme, but we have been doing quite a lot of work so far to do lots of other sessions like this with some clinicians joining us. So there's lots of information available to you, even though the public engagement period is coming to an end. So you can see there some documents that we've produced, and there are a suite of 4 related documents. So the first and really the starting point for us is the clinical strategy. And I'm delighted to say that we have our Director of Strategy with us this evening, so she can ask any questions that you have around the strategy behind the proposals that we're talking about. The strategy has a partner document called the Clinical Brief, and if you like your detail, that's probably the document for you. It does describe where each of our services is likely to be provided from, and you will hear tonight that we are making some changes to which sites deliver which services. And then there are 2 engagement documents. One is a summary document, so slightly shorter, and that's the one to read if you're very, very pressed for time, but you are very welcome to look at them all, of course. We're also running a survey, and we hope that you will make time to complete the survey. So a little bit of background. We have been working for a long time with our commissioners, Herts Valley's Clinical Commissioning Group, to secure enough money for our proposals. And at the heart of our proposals is this idea that three's company. So I know that the phrase is two's company and three's a crowd, but we actually think that our 3 hospitals can work really well together. And what we want to do is to redefine the range of services that they provide and make sure that each site has a unique purpose. And broadly, these are the services that would be provided at each site. So Watford would be our site for emergency care, specialist and complex care. St Albans is where we will provide planned surgical care, planned cancer care, and an urgent care service. And Hemel Hempstead is the site where we would focus on providing planned medical care and care for patients with long-term conditions. All of our hospitals already run on those lines at the moment, but we want to emphasise that a lot more than we do currently. Urgent care services will be delivered from all sites, and there will be a small range of outpatient appointments at all sites also. And the asterisk there just describes just explains that the minor injuries unit at St Albans is currently closed, and when it reopens, we anticipate it delivering a slightly broader range of services, more along an urgent treatment centre model. So our work around redefining each of our sites also has another driving force behind it, which is about consolidating and not duplicating. So we really want to see our clinical teams working together along the lines of the specialty service that they deliver. And that is what our clinicians have told us that they want. So when we knew that we had some investment coming our way, or that we were likely to receive significant funding, we've really taken a fresh look at how our sites and our services run. And this is a message loud and clear. And there's lots of reasons that teams want to work together in larger numbers rather than be stretched across the 3 sites. So that's about development and training, so that junior staff always have a senior clinician on hand. And that's also good for seeking a second opinion if you need one urgently. Also, it is very good for teams to be able to cover each other. So rather than risk a clinic being cancelled or an appointment being cancelled because of unexpected staff shortage, there's a sort of strength in numbers. And also, as you will hear, we are providing new diagnostic equipment at our 3 hospitals. And so we want to make the most of that investment by having the right teams and the right equipment together. On the bottom of this slide is a fact with a rather large number in, and that is that we want to reduce our outpatient appointments by up to 200,000 every year. And we will be doing that through a range of measures, but one of them being how I'm talking to you today. So really moving a lot more of our appointments onto a digital platform. And we've done this primarily because of COVID, although we were thinking of moving this way anyway. And we have found that it's been well received. Also, we are working with partners in the NHS and social care and other organisations, and Claire my colleague will tell you a little bit about that if you're interested. So moving some of those services away from hospital settings. So all of these things, digital and looking at how differently we can provide services and making your appointments fit better together, they're all ways that we can reduce the number of patient journeys and trips that you have to make. Digital transformation, as I've just began explaining there, is a key enabler for us. It really will change the way that we work, not just things like Zoom or Teams or the different technologies that we have at our disposal, but also the electronic patient record, which will allow us to see your information at a moment's notice, to share it with your permission with other organisations that are providing care to you, and also to see what other organisations have done in terms of treatment they've given to you. So it allows us to see a more rounded record. It will allow clinicians to work from different sites and all see the same record, and it will really speed up the way that we can deliver care, and it will avoid also those instances where clinics or procedures are cancelled because the notes aren't available. And the electronic patient record will also give us a really high degree of accuracy. And importantly, it will free up time to care because our nursing and our medical staff will be spending less time laboriously re-entering data because the record will be in far better shape and it will need less manual input. So as I was saying, feedback so far has been very good to the virtual appointments that we've been running. We have been looking after over 4,000 patients with COVID in a remote model. So that means either they've been in hospital and they've continued their recovery at home, or that we've managed to avoid an admission in the first place. And Watford General and Hemel Hempstead are the 2 hospitals that are managing that programme. But we have now, as I said, treated over 4,000 people. We were the first in the UK to set up a virtual COVID hospital. So there is an awful lot that can be done through using technology to keep patients safe, but also to enable them to be where they want to be. Diagnostics is also a key enabler for us, and we are really looking at some serious upgrades for our diagnostic equipment across all 3 sites. And as I said earlier, this is about making sure that each site fulfills its unique purpose. So if we are grouping our staff together and our services together, it is essential that they have the right diagnostic equipment. And there has been and will continue to be investment in diagnostics because it is understood that this is at the heart of providing really efficient services for patients. Thank you. So these are the range of services that we plan to provide at Watford, very similar to how they are now, with the addition of some new services like inpatient neurology, inpatient chemotherapy, interventional radiology is another one. So we are hoping to bring some more specialist services to Watford. So we're sometimes described as a DGH plus, so we like our jargon in the NHS. So DGH stands for District General Hospital, and the plus, or sometimes a plus plus, indicates that although we do the range of district general hospital services, we also have areas of increased specialty. So we want to grow those because that saves patients travelling into London or other parts of the country for services that we think we could provide. And we are also developing a multi-storey car park, which I'm sure will be good news to those of you who might have experienced trying to find parking at Watford General Hospital. So this is a view from Vicky. Vicky Houghton is our intensive care matron. She has had an amazingly difficult and challenging year, and her view is there because we wanted to sort of tell you through staff what the views were to our plans, because we know that some parts of the community might think that one new hospital on a single site is the ideal, but actually our staff are very enthusiastic on the whole about the model that we're talking to you about, and this is Vicky's view. So being based at Watford and knowing that staff live locally to the hospital, she's very keen to see development on the site and thinks it will be a real morale boost to see it sort of literally rising out of the ground. And also she's been quite involved in some of the planning around the ward spaces, and she gave a session earlier in this series saying how assured she was at the model that we were using for the rooms, because she could see that they could be quickly converted to provide critical care. Obviously, we hope that isn't needed in the future, but it's definitely informed our planning so far. So this is the range of services at St Albans City Hospital. Again, very similar to the services that we're providing currently, but more so. So we want to increase not just the volume, but also the complexity of the surgery that we deliver at this site. And by having greater numbers of staff at the site, including senior surgeons and consultants and clinical nurse specialists, that will increase the safety and allow us to do more at that site. We will move endoscopy from Hemel Hempstead Hospital to St Albans City Hospital as well, because that is a better fit for planned surgical care and also planned surgery. Emergency or urgent endoscopy will remain at Watford, but it's the planned endoscopy, elective is the word we sometimes use instead of planned, that will move from Hemel Hempstead to St Albans. And this is Mr. Freddie Banks, consultant urologist, and he is really driving hard to improve not just the care. We don't think there's an issue with the care as such. It's the way that it's organised that is detrimental for the experience of our patients. So he talked in his session about the number of different appointments that a patient who might have suspected prostate cancer would have to go through, the number of hospitals to visit for different kinds of scans. And so he is really pioneering a very simple, straightforward pathway, we call it, the steps that patient has to follow to get the treatment that they need. And we're not waiting for someday in the next 5 years or whatever to flick the switch to make this all happen. We are working towards it as we pursue the funding. We are working towards better ways of working all the time, but he's particularly keen that our patient pathway for surgical patients is much smoother, much quicker, and just simpler, and saving them lots of additional trips. So this is the range of services at Hemel Hempstead Hospital. Although our plans show the lion's share of the investment going to Watford, we think that what will happen at Hemel Hempstead Hospital is quite transformative in terms of the service. So we want to create a centre of excellence for planned medical care and for people with long-term conditions. And this is very much along the lines of emerging healthcare models in the States, different parts of Europe, and the outcomes are excellent. And it's really about trying to keep patients out of hospital or out of an acute hospital. So, the view of some of the clinicians that have spoken at previous meetings is that admission to hospital is actually a failure, that we should do everything we can to keep people as well as possible in their own homes or wherever they live, to avoid them needing to be admitted as an emergency patient. So quite a range of services to be provided at Hemel Hempstead Hospital, a real sort of shift of gravity from the other two hospitals towards Hemel Hempstead Hospital to, as I say, allow it to become a centre of excellence. And in a population with around 30% having long-term conditions and an ageing population, we think it's only right that we give a lot of consideration to the care model for that group of the population. And this is Dr. Sandeep Ballara, who has been at the Trust for around 20 years, but has spent most of his time at Hemel Hempstead. And he makes a really good point that great care doesn't just happen on a busy emergency site or in a ward. So he says, you know, hospital care can be delivered in a calm environment where all the needs of the patients have been thought through before they even arrive. So real advocate for how we want to see a hospital at Hemel Hempstead run. And this is the engagement timeline. So as you can see, we're at the end of our period of public engagement. We will do a second phase after the local elections. And so when all the results come in from the survey, which I'll mention again in a moment, we will look at all of that feedback and comments that people have made either on the survey or from meetings like this. And if we feel that we have been unclear about anything, that there is a need for extra clarification, then we will go out with that. We will make sure there's further information. And also in the second period of engagement, we may do focus groups or particular groups in the community that we don't feel we've reached sufficiently. So it just gives us a chance to listen to what people have told us and to go back out and to engage again. And then the board, our trust board, will consider all of that information and they will use it when they look at the clinical brief in July and later on in the year when they make decisions about the way that the services are to be delivered across the 3 sites. So it's really useful to get the views of our community, and that's one of the reasons why we've also been doing meetings with community groups when they've invited us. So as well as these public meetings, we've done a number of meetings to different groups around West Hertfordshire. We've commissioned an independent company to provide the survey. We'd like to think they're good at healthcare, but devising surveys isn't quite our strong suit. So we've commissioned an independent provider, and that also gives us a little bit of impartiality, and they will look at the results too. So that provides some distance between us and the feedback, just to make sure, as I say, that it's managed impartially. And if you're interested, then the details of the company who have devised the survey are there on the screen. So different ways to get involved. We have extended the closing date of the survey, and that is now the 28th of March. So no excuse not to do it. We really do want to hear from people across the whole of the area that we serve, and it's for anyone. So staff are doing the same survey as non-staff. Anyone can do it. So if you've got friends and family who are interested, please share it with them. And again, there's another link to our website where all the information that I've mentioned tonight is available. So this is the QR code. If you're good with tech and you've got a mobile phone, you can hover over the QR code and that'll take you straight to the survey. And then it's time for questions. So I think I have a question. Now, I would say that we have asked throughout the whole of this series for questions to be submitted on chat, and we do need to stick to that because otherwise it might feel unfair to those people who haven't been able to ask questions in their own voice. So I'm afraid we are going to stick with that. So please, if you do want to submit a question, if you can submit it via the chat function, we will do our absolute level best to ask it, to answer it even. So thank you. I think there was a question out there, but if you wouldn't mind just sending it to us via via the chat function, that would be great. I believe one is just coming, so I will just wait for that. Claire, can I ask you if there was anything that you wanted to say about working with clinicians on the strategy? Because I know you would think it's been really hard to involve clinicians, but actually they've had we've been pleased, haven't we, with the level of engagement that we've had from them.
Yeah, absolutely. And I was just thinking that this might be a good opportunity to just give the strategy a bit of a plug, because we focus very much in these sessions on the clinical brief and the services that we're wanting to provide from each of our 3 sites. But just stepping back to look at the clinical strategy, we have as an organisation 4 overarching strategic aims, which are about providing the best care from so now I'm going to forget them, aren't I? Best care, best value in terms of how we deliver our services around our finance, with great people in a great place. So obviously a lot of this work is about great place, but the clinical strategy is really focusing on the best care and how we deliver the very best care to our patients every day. So the overarching theme around that best care, and Louise, you mentioned this slightly earlier, is we want to make sure that everything we do is of a really high standard, and that where we are able to go over and above what you would normally see in a local hospital, we do that. And we've got loads and loads of examples of where we are already doing above and beyond what you might expect to see locally. So respiratory is a really good example of that. COVID virtual hospital is one, but a lot of the work we're already doing through some of our ultrasound endoscopy services is really cutting edge and much better than you'd get in most general hospitals. Cardiology, we have a really large range of procedures that we're able to provide on site for people. Gastroenterology is another one with those endoscopy services. And the advantage of all of those things is that for patients, it means they can access care locally. They don't have to travel to London or to other specialist organisations to receive that care. But also, really importantly, it helps us to recruit and retain really, really high quality staff, both doctors and nurses, which then means we can provide even better services. So really what we want to do is to make sure that everything is as good as possible, and where we can stretch those services and deliver a much wider range, then we're seeking to do so. And the strategy sets out some of those places where we are already really good and where we want to build on that. We are also always aware that some of our services are maybe slightly smaller or not at the best size to make sure that we can always deliver a consistent service. And particularly if we're running with a small number of consultants, for example, and then somebody leaves or is unwell, that can really impact on patient care. So for those very small number of smaller services, we are going to work with other providers locally to look at how we can make those more sustainable, how we can make sure that we don't have those cancellations, how we can make sure that out of hours we can deliver good services as well as in hours. So that's our big sort of key theme.
Thank you.
Then, sorry, shall I pause?
Yeah. Go on.
Yeah. So then we have 3 then key things we want to change in our model of care. So the first of those is that we want to integrate care better with community, with primary care, with mental health, with social care, so that people's experience of care is much more joined up than it is at the moment. And for those people who've attended or seen the meetings where we were talking about Hemel Hempstead, I think that really came across in those one-stop clinics that we talked about, the way we want to join up that care better. The second thing we want to do is to make care more personalised for people, so that we are working to understand the goals of an individual, working to understand what a care plan might look like that takes into account their needs and how we help them to manage their health and care in line with that care plan, making sure people have all the information they need to make a good decision about the right care for them, and in terms of informing their consent. So a lot more we can do to really personalise care better. And then the third thing is around making sure our care is consistent, so that whatever time of day, whichever clinician you see, the care you will experience is consistent and in line with best practice. So those are the big changes we want to make to our model, supporting that best care aim.
Thank you. So for anyone who thought the strategy was was sort of dry, I think Claire has just given a perfect example of how it is really, really, really patient-centered. So that was really interesting, and I had the job of proofreading the strategy. I didn't really need to because there weren't any mistakes, but and I wouldn't normally pick up a strategy document, I have to say, but I found it really interesting and very, very personal to me. So I thought it was I think it's a really good piece of work. So do have a look at that when you're looking at all of the documents. So I think, Mike, we did say, because we know it'd be easier for you to ask a question in person. So we have said that would be possible. We don't want to exclude you for if chat is difficult. So please go ahead.
Thank you. It takes me a while to type, you see. I have a few questions, but if I ask one and then you can go to some one else, and then if I can ask others. With regards to the survey, it did on the computer, it did seem very weighted, to particular answers, so it could easily get it the wrong way round. I think the numbers change, so you're answering good is one side, and then it's good is the other side. And so I think with the survey, it's not very good that way. And also, if you haven't been to one of the sites, it doesn't ask you the questions about that site. If you've not been there for 2 years, well, the reason why you've not been might be because of a reason such as you can't get there, or you avoid going there because of that site. So when you were talking about the survey, I do think that that there are flaws to that survey.
Okay, thank you. I will pass that on to the survey provider, particularly about, you know, what you're saying about the swapping. So where in one answer 5 might be good, or, you know, where it could be easy to put in the wrong answer. So I will pass that on so that we look for that, and just to see if that has skewed anything. It was road tested, so it didn't come directly from the survey provider to us. We did, you know, the company did test it with quite a few people before it went live, you know, so but yes, we can definitely make sure that goes back, so that we can look out for any answers that might have been inadvertently filled in the wrong way. Thank you. We'll stick with you, Mike, if you're ready to go with another question.
Am I the only one here?
You are the only one.
Okay. Well, I can go.
We've been busy, so we've had I think we've worn everyone out, Mike. It's just us tonight. So the floor is yours.
I can ask lots then. What were the cancer services that we were thinking of having at St Albans? What were you thinking of having there?
I might ask if Claire can help me out. And also I would at that point suggest that if you do want to find out more, it's definitely worth having a look at the clinical brief. But Claire, do you want to just give a brief overview of what you know, and then I think it's down to the detail in the document, isn't it?
Yeah, I will do my best. So cancer pathways are made up of a mixture of different things. So, you know, at the start of a pathway, you might have outpatient appointments, you might have diagnostic tests, you know, so different types of scans or biopsies or things like that. Then later on in the pathway, you might have things like chemotherapy, radiotherapy, or surgery, depending on the nature of your condition. So in terms of what we will be doing at St Albans, we would not be doing chemotherapy or radiotherapy, but we would be doing everything else. So the idea really of that new pathway is that instead of going to multiple different places for the different elements of the testing, you would have everything done at St Albans. You might then need to go elsewhere for your chemotherapy, radiotherapy, and some elements of surgery if the surgery is specialist. But otherwise, we would do it at St Albans. And what we will be aiming to achieve is to do that through a one-stop model, so that you're not going to St Albans 5 times for 5 different diagnostic tests as far as possible. We were trying to do that on one day, so that, you know, if clinically that's appropriate, that's what we were trying to do, so that we reduce the amount of time people are waiting to find out whether they do or don't have cancer, and make that pathway much smoother for them.
So would that include like a recovery ward, or like when you're for recovery after cancer treatment, or?
Yeah, so if you've had surgery, then there will be day case and some elective beds on the site, and that would include, one of the changes we're making is to put some higher dependency beds onto the St Albans site so that we can do more complex surgery there. If your surgery was very complex and might require a much longer stay, it's likely you would not be having that at St Albans, because our most specialist work is either done at Watford or at a tertiary a teaching hospital in London. But certainly, you know, if you'd had surgery that then needed an element of recovery time, that would be happening at St Albans.
So I think having some cancer services at St Albans would be good, because obviously you have the Rennie Grove Cancer hospice there, but obviously there are plans to move Mount Vernon at the moment, and then you were talking about having it all together. You'd be having Mount Vernon in Watford, and then the rest of the cancer treatment in St Albans. So you would still then have you would still have a gap between you'd be on different sites still, even though your aim is to get them all together.
So if at the moment people would go to Mount Vernon for chemotherapy, radiotherapy, or some types of more specialist scans, as you say, the Mount Vernon services are currently looking at an alternative site, and at the moment they've identified Watford as the preferred site, which, you know, we would be very excited about if that were to happen. The chemotherapy and radiotherapy services would then move from Mount Vernon to Watford. That would be the plan. We would not be intending to have those at St Albans, but they're not at St Albans now. So by having them in Watford, that would be easier for a lot of people to access than Mount Vernon. Some of the scans that people would currently travel to Mount Vernon for, we would be expecting to make available in St Albans. So that would be one of the benefits that we would have from extending the range of services at St Albans, would be to reduce some of that travel to Mount Vernon. But yes, the parts of the cancer pathway that we are not planning to put at St Albans are chemotherapy and radiotherapy. They are more specialist. They require different levels of backup in terms of the acute hospital, and they require a lot more space than we have available in St Albans.
Probably worth adding also, Claire, that they're provided by different, the Mount Vernon service will be provided by a different organisation.
Yes,
so probably,
UCLA.
yeah.
So let me see. The improvements at the Hemel Hempstead Hospital, what improvements to the site are you planning or envisaging at the moment. Obviously, it seems that the actual buildings have been quite neglected, really. And are you planning to bring back into use all of the buildings at Hemel?
No, we're planning to consolidate services into a single building in Hemel, which is the Verulam wing. Looking at Louise to nod. So yeah, so that's our newest and best building on the site.
The one at the top of the hill is the Verulam.
Yes, I think so. Yes. So that's the newest building on the site, and we are then intending to do a fairly extensive renovation of the building to make sure that all of the space is suitable for the services we want to provide there. So the urgent treatment centre would relocate from its current building into the Verulam wing. We would have an extended range of diagnostic services, and then we would be bringing together all of our medical specialties into a single building, so that we can look at, again, integrated one-stop clinics, both within specialties but also across specialties where people have more complex multiple long-term conditions. So a lot of the change. So apart from the consolidation into the building, the exciting thing about Hemel is the range of services we're able to offer, and the much improved clinical model that we expect to be able to provide for people with long-term conditions.
The general good thing with Hemel at the moment is that there is parking. Obviously half of it's not with the buildings not being in use. There's more parking than would be if it was busy. But like some of the parking, I'm thinking of like the disabled parking at Hemel has it isn't practical. If you know Hemel, at the top of the hill, if you go in the top entrance to that top building, they have allocated disabled parking, but it's actually smaller and tighter than the other parking spaces. So it's not so is anything planning to be done to actually work on actually on that sort of side?
Yes, Mike, we will be setting up a transport and access group. So we will be looking at the ways people travel to our sites and also how they manage when they're on our site. So that work will be done as plans for Hemel emerge. So at the moment, because of the length of time the planning process takes for Watford General Hospital, because of the magnitude of the changes planned there, the first hospital to go through a planning process is Watford General. So a lot of focus is on getting ready for the outline planning application, which is submitted in May. And if you're interested in that, then there is a public consultation on the outline planning application, and that starts on this Friday. So once that is on its way, then the architects can turn their attention to Hemel Hempstead and St Albans. And I should just say that the order in which the architects are working doesn't necessarily dictate the way in which the buildings will be renovated, rebuilt, refurbed. So it may be that work is brought forward on St Albans and Hemel Hempstead before completion at Watford. So we do absolutely hear what you're saying about parking, but it would be good to have you with us to talk about parking when we are further forward with our plans.
The other thing with so with Hemel at the moment, as a hospital for when you go for appointments. You were talking about how that you'd have the teams together to improve to improve things. At the moment, it seems that because you have the people in Watford and Hemel, for an appointment at Hemel, the consultant might be coming from Watford, so you then have it's then delayed. You can get quite delays for appointments because the consultants isn't based there.
I think what we were saying. Oh, sorry, Claire. I'll just start, and then I know you've probably got more to add. But what we're trying to do with our grouping of our staff is to avoid the travelling, so that the services that are currently spread over 3 sites will probably move to 2, and those that are over 2 sites might reduce to 1. And so the consultants are based in one place and they're travelling less. So we anticipate less travel overall for staff and patients. But Claire, you probably can add to that.
Yeah, I was going to say exactly the same thing. I mean, that is absolutely one of our principles, that by consolidating onto 2 sites for most specialties, and then how we organise people's job plans, one of our key objectives is to reduce that travel time, and that's something that the medical director is very keen to do, to make sure that we don't waste or lose people's time in travelling, and that we don't then have a knock-on implication for patients with people being late.
I can see how that would be good from my experience, but I think that might, rather than it will just move it to the patient needing to move from different sites. I think more but I'm rather than because I know at the moment, if you have an appointment in Hemel, that they could be coming from Watford. It was talking about having urgent care at both St Albans and Hemel. What would that cover, and would both the urgent cares cover everything, or would there be a difference between the 2 hospitals? I think at the moment, I'm not sure if it still happens, but I think if you had a broken leg, you would go from St Albans to Hemel, or because they could only do arms or something at one point. Could they both? Are they both going to do sort of the cover the same things, or would you go to one for one thing and one for the other?
So I can pick up that, and I'll come back to your other point about patients travelling as well. So in terms of urgent care, we have a difference at the moment between the 2 sites, as you say. So the service we have at Hemel Hempstead is a full urgent treatment centre. There is a national definition of what has to be delivered for it to meet an urgent treatment centre specification, and that includes a wide range of both minor injury and minor illness services to be able to meet the vast majority of people's urgent care needs. So that is already in place at Hemel. The service we have at St Albans at the moment is a minor injuries unit. So that only deals with minor injuries and doesn't deal with minor illness, and sees a lot less people per day than the Hemel service does. The service at St Albans has been suspended for the last year because of COVID. because we have been keeping St Albans as what we call a green site, so COVID free, COVID safe, we have not wanted to have people walking onto that site with unknown health issues and health conditions. So that's why the MIU is temporarily closed at the moment. We are not yet clear what the future model will be for urgent care in St Albans. So we are planning to have an urgent care service on that site. But the CCG, Hearts Valley's Clinical Commissioning Group, is currently doing some work to look at what the needs of the local St Albans population are, and to then see what we think the right service model would be for urgent care in St Albans. And they will be coming out to engage with the public, probably sort of June, July time, I would imagine, after the local elections. So at the moment, the St Albans model is not yet clear, but there will be engagement on that later in the spring, summer. Just going back to your point about patients travelling, it's not our intention that people will be travelling more as a result of these changes. We are continuing to offer most services on at least 2 sites. And for some of our higher volumes services, so things like blood tests or maternity antenatal appointments, we will continue to offer those on all 3 sites. There will be a relatively small number of people who currently have outpatient appointments in St Albans who would move to Hemel and vice versa. And there will be a small number of people who would move from Watford to Hemel and St Albans. That latter change should be positive, because if you live in Watford, you would still go to Watford. But if you live in Hemel or St Albans, that may be a better opportunity. But going back to something that Louise said earlier, we currently have just over 500,000 outpatient attendances per year. And we think that a significant proportion of those, and we currently think maybe around 200,000, we could actually deal with completely differently through virtual appointments, virtual consultations, or possibly through changing our follow-up model so that you don't necessarily need to come in for a follow-up if things are going well. So actually, we think that there will be a significant reduction in the number of people travelling. And on top of that, by looking at this one-stop approach at all 3 sites, so that instead of having to come 3 or 4 times for different outpatient attendances or diagnostics, you might travel once, be there for slightly longer, but not then have to travel multiple times for different appointments. So we would completely expect, through the changes in our service model, that the total number of times people travel to our sites will significantly reduce, and that will far, far outweigh the relatively small number of people who may have to travel slightly further to come to Hemel or St Albans in the future.
How long, with the changes in Hemel and St Albans when the A&E was taken away, obviously the urgent care was going to be 24 hours, and that didn't last very long. And then it was it 8 till 10, and now it's something the hours just get reduced after it was introduced. How long would the urgent care actually stay in St Albans if it was introduced, and how long will what would the opening hours be, really?
So from St Albans, I can't answer that question, because that will all be part of the conversation that I've already mentioned, in terms of what we think that model of care needs to look like, what will best meet the needs of the local residents, and then how and when would that best be delivered. So there will be a separate engagement process run by the Clinical Commissioning Group specifically on that question. But I would say, when the hours reduced in the urgent treatment centre, if I take Hemel as an example, the reason for that was because there was no demand. And actually a similar thing has happened in many, many places in the country. The number of people attending urgent treatment centres overnight tends to be 1 an hour, sometimes less. And so in terms of how we best target our resources, it's much better to have more people available during the day when people are attending than to be staffing a unit overnight where you may literally have 1, maybe 2 people an hour at best. That's been the recent experience in other places.
I thought at the time when it was reduced from 24 hours, it was due to staff shortages.
Well, that, yeah, I have to admit, I don't have some of that history. So the staff shortages may also have been a factor, but it will be a combination of attendances and staff shortages, because we only have a certain number of people, and we need to use those to the best effect that we possibly can.
So the plans that you're suggesting at the moment, with what you're planning to have in Hemel and in St Albans, once you've built Watford as a rebuilt Watford, you could decide, because of staff shortages and things like that, that actually you won't go ahead with it.
So we have got and have had an urgent treatment centre in Hemel for a long time. We don't have any plans to change that service at all. It's a very busy service. We have over 120 to 150 people a day going through that Hemel urgent treatment centre. We absolutely would not want those people to have to travel to Watford, and we wouldn't have the space in Watford to be able to manage them if they did. So there are absolutely no plans to change that urgent treatment centre, and the national specification requires it to be open at least 12 hours a day. So they're also, that there are commitments as well in terms of the opening hours. St Albans, I just can't answer that with the level of detail that you're wanting, because it is a question that is currently up for some discussion. But the reason it's up for discussion is because the minor injuries unit only deals with injuries. It only sees on average less than 40 people a day, and much lower than that on some days. It's therefore not necessarily meeting the demand and the needs of the people in St Albans, where actually there is far more demand for minor illness services than there is for minor injury services. So part of the purpose of looking at that urgent care service at St Albans is to make sure we're actually providing a service that people need, rather than one that people don't need. And if the conclusion of that engagement is that it stays as it is, that's what it will do. But if the conclusion is that something else would better meet the needs of people, then that's the conversation we would want to have as part of the engagement.
I think part of the problem with the MIU and the urgent care at the moment is not actually knowing what they actually do and when they're actually open, and not and if you don't know necessarily know what's wrong with you, to know what you don't know what's wrong with you. And if you knew what was wrong with you, you might not need to have gone anyway. But I think there's a confusion with what it covers, because it's quite for everyday people. We don't know what they do.
No, I think it's a really, really good point. And one of the reasons that that nationally a few years ago they came up with the specification for urgent treatment centres was precisely that. There were so many different services being provided by the NHS that had similar names for different services or different names for the same services. They said this is wrong, this is not fair to patients, people don't know where to go. And they therefore were very explicit that either you meet the specification for an urgent treatment centre, or you cannot provide you cannot continue to provide a walk-in service. So actually, just slightly contradicting something I said earlier, we are not going to be allowed to provide a minor injuries unit in the walk-in service way that it is at the moment. We would either need to extend that service significantly to meet the urgent treatment centre specification, or we would need to move it to a booked service. So it might still be dealing with minor injuries, but people would need to ring in advance to make an appointment. But I think it's also really important in terms of how you know where to go, to use NHS 111. So there's been a lot of campaigning, you may or may not have seen over the last few months, for people to ring NHS 111 first. And that's been really important during COVID because, if you can talk to somebody on the phone and they can work out what's wrong with you, or if you can get some support from a pharmacy or a GP practice, that means you don't have to go to an emergency department where you might come into contact with somebody with COVID. So what we would encourage everyone to do is to ring NHS 111. They will help to determine the best place for you to go, and they will also be able to then book you into an appointment. So if you were going to the urgent treatment centre in Hemel, you can walk in, but you can also ring NHS 111. They will book you an appointment, and you can then turn up and you will be seen within, ideally at your appointment time, but within half an hour of that appointment is the expectation that we're supposed to meet. So that's what I would encourage you and others to do, is to ring 111 if you're not sure where to go.
Thank you, Claire. I was just going to say that because that should really save you the travel anyway, because they have an expert view on what services are up and running at the very moment that you call them, or what appointments they can slot you into the next day if it's urgent but not so urgent that you need to see somebody at that minute. So we are increasingly trying to direct people to that service.
Going through another part, what are the plans for I think we've in Watford, so what are the plans for the AAU department? At the moment, it's far too large. It can't really cope with the amount of people they have. How's that? How are the changes going to improve that?
So I'll have a crack at that, bearing in mind that neither Louise nor I is a clinician. So what we are trying to do in the new hospital is to make sure that we are designing something that has got the right size for everything we need. So we are going to have, we would expect to have more ambulatory care and frailty unit support, so that if somebody comes into the emergency department, rather than necessarily needing to be admitted for assessment, they could go into ambulatory care or the frailty unit, where they would be able to receive same day care and normally be able to go home on the same day where that's clinically appropriate. So we will have more of that. We are also looking really carefully at what we think the demand is for each of our specialties and for care of the elderly, so that we have the right number of beds for each of our specialties. So part of the problem often is that there isn't enough room in the rest of the hospital for people to come out of the AAU, the assessment unit. So what we would be intending to do would be to have a relatively smaller assessment unit, but more space in the specialty beds and the care of the elderly beds, that will therefore enable people to move in the way that they should do, because the principle of an assessment unit is that you should only really be there for 24 to 48 hours, and we know that a lot of people stay there much longer than that at the moment. So we think both our pathway work and just how we design the right number of beds in the right places will help us to change that model.
And that's really the work that's going on at the moment, looking really closely at population growth, different ways of treating people, to right size the hospital, to really understand it's so important not to build it too small, but it's equally important not to build it too big because of the huge waste of resources there. So we've got to work really hard to get it absolutely right, sort of looking into the future and taking into account all the impact of all the things that we're currently doing, which could reduce the need for beds or not, you know. So that's right where we are at the minute. And our next plans that we put out into the public later this year will have a lot more detail than we can currently give. But if you want to get an idea of how the building at Watford is looking, then the public consultation on the buildings, which launches on Friday, will give you a bit more information, or at least a better idea.
Because I would agree that with the AU being reduced in size and having them more actual proper beds, because yes, you do spend a lot more than the 2 days or something in the AAU than you're supposed to at the moment. On
Can I just, sorry, before you ask, but can I just ask if you could maybe choose your last question? If you've got a few, is there one best out of all of those that you particularly want to ask?
When you said about you were wanting to deliver things locally, why were just the current sites chosen to be looked at rather than to look at other sites, either a new hospital, or why wasn't a new site in St Albans or a new site in Hemel thought about? Obviously, Hemel's built on the side of a hill. Watford's built on the side of a hill. What was the thinking behind choosing just the existing sites rather than thinking of either a new site? Obviously, right, Hemel's quite good because it's close to the town centre, and you can easily access it. But what was the thinking process behind choosing that?
So I think, Mike, that the best place for you to find out more about that would be, there's a good paper on our website that we took to Herts County Council Scrutiny Committee in February, which sets out our rationale. So that is a question that I think we've probably addressed in other documents. So
because what I've seen, it doesn't seem to, you haven't looked at like looked at other options.
Yeah, we have over the years. We've looked at many different options.
But it's
very
not clear
many.
that you've looked at, say, other town centre sites.
Well, as I say,
it
the
doesn't
information
say that in any of the documents I've seen. So, what document are you talking about that says that?
I think a good, and it's also a recent one, is the paper that we took to Herts Scrutiny Committee topic group in February, which gives a broad overview of I think it also contains a number of sites, different sites that we've looked at.
That doesn't say about town centre sites, does it?
No, I was just coming on to say also another factor that's important for us is speed. So I don't know, it sounds to me like you've been to our hospitals, so you know that we really want to move quickly. And so the smoothest route we felt, and certainly at the Watford site, this has been backed up by an independent report, was to use our existing sites, because this saves an awful lot of time negotiating land sales, land acquisitions, because we have 3 sites at our, that are available to us already, and additional land next to the Watford site. But I am sorry, Mike, but I am going to call it to an end there. This session, like all the sessions, is to discuss the proposals for the care that we want to provide and how we will reorganise that.
Okay.
And discussions about the site have happened in the past, it's a well-rehearsed topic and a lot of information is out there. So as all of the sessions have been to look at the service proposals, that is really, it's only fair to everyone who's attended all the sessions so far that we keep the focus on the services. So thank you very much for joining us this evening, and please do look at the documents, and also you've got our email, so you can, if you can't find the document that I mentioned, then I'm very happy to send it to you. So I'd like to thank Claire for joining us, and thank you for all of your questions. And I hope if you haven't filled in the survey that you will fill it in, and thank you very much for your feedback on that.